So I think we'll make a start. We have quite a few people already in the session. So good afternoon, welcome, and thank you for joining this session. My name is Kat Omer. I'm a project officer for Central and South Genomics and also the project lead for this NHS England transformation project. Many of you are aware of the purpose of the GMSAs. Essentially, our aim is to embed genomics into routine care across the country, ensuring equity of access, and providing faster diagnoses and more effective personalized treatment for our patients. So in this session, we will be exploring into the exciting realms of liquid biopsy technology and explore the insights gained from this ongoing transformation pilot. So our expert speakers, I shall say, will share findings from their project, showcasing the potential for earlier cancer detection and personalized treatment. During this session, we will hear from Dr. Marcus Reamer, who is the clinical lead for our GMSA for ctDNA, as well as he's a medical oncologist at Hampshire Hospitals. Followed by Dr. Tom Gildart, who is also a consultant medical oncologist at University Hospital Dorset, and Joe Wilson, who is the lung cancer nurse specialist at University Hospital Southampton, followed by Professor Alistair Greystoke, and I don't think I need to introduce him. Everyone must be aware of him. He's also the clinical director for North East and Yorkshire for Cancer Genomics Medicine Service. And obviously conclude with the opportunity to ask questions. So thank you for your participation and attention. And without further ado, I will hand over to Dr. Reamer.
Thank you, Kat. Good evening, everyone. Thank you for joining us. Some of you may already be involved in the NHS England National ctDNA transformation project, and others are looking to come on board. So we're going to tell you a little bit about the background of the project, its utility, and if you are not involved, I would hope that this will encourage you to get in touch and sign up. These are my disclosures. The State of the Nation report, or the National Lung Cancer Audit, came out a couple of weeks ago. It reflects data from 2022, and here's a few snippets just to share with you. So in 2022 in England and Wales, 39,000 new lung cancers were diagnosed. Around 1 in 10 of those were never smokers. The average age was 74 years old, and only 18% of patients went on and had radical surgery. That number has gone up compared to pandemic levels where it dipped to 15%. Overall survival for lung cancer in general remains 48% 1-year survival, so still under 50%. With average median survival 327 days. Half of patients are diagnosed with advanced stage 4 lung cancer at the time of diagnosis, and a third of those patients are being diagnosed after presenting to ED. Of the patients with stage 4 or advanced non-small cell lung cancer, only 6 in 10 are receiving any systemic therapy. There are significant waiting times in England, on average 41 days from the start of diagnosis to the start of treatment. So I think all of those figures, even though they're slightly better than in the years before, suggest that there is massive scope for improvement. And part of improving outcomes is earlier diagnosis, starting patients on the right treatment sooner. And that's what the ctDNA project or pilot is really looking at. So non-small cell lung cancer is a diverse group of different molecularly driven diseases, and there are key oncogenic driver mutations, the most commonly known being EGFR, which has now been known and druggable for 20 years. These oncogenic drivers can be found in any patient with non-small cell lung cancer, but there are enriched populations which are adenocarcinomas, never or light smokers, females, patients of a younger age, and Southeast Asian ethnicity. That said, we still find mutations in older, heavy smoking males. And the importance of looking for these oncogenic drivers is in order to be able to offer targeted therapies. And most of the time, we're talking about the oral TKIs, the tyrosine kinase inhibitors. So there are currently 23 FDA approved. These are small molecule inhibitors, and they work by inhibiting intracellular signaling pathways within tumor cells and blocking growth signals. Not all, but a significant number have particularly high response rates, often higher than a lot of other comparable cancer treatments, including high intracranial response rates. They tend to have a very different toxicity profile to chemotherapy and immunotherapy, often skin and GI toxicity. There are now other targeted therapies that are on their way to the clinic, not currently available outside of trials in the UK. There's bispecific antibodies and antibody drug conjugates, which is normally a combination of an antibody and a chemotherapy agent. So watch this space. Oncogenic driver mutations are genomic variants which include mutations, translocations, gene amplifications that are responsible for both the initiation and the maintenance of cancer. And the reason why this matters is if we find these oncogenic drivers and we start the appropriate targeted therapy, often the overall survival outcomes can be massively improved, especially when compared to conventional palliative chemotherapy or even chemotherapy and immunotherapy. So I've listed a few different mutations there and the trial reported median survivals, and you can see that quite a few of them have median survivals over 2 years. For example, in ALK positive lung cancer, 5-year survival of first-line treatment was 62.5%. So really important to find these drivers to start patients on the right treatment. There are a number of patient support groups for individual alterations and variants. There's the ROS1ders, the KRAS kickers, the N-trekkers, the RET renegades, the BRAF bombers, the MET crusaders. And if you do find these variants, I would direct patients towards some of these support groups because they're very good. We are now testing for a larger number of oncogenic drivers, and it's increasing. As an oncologist, NHS England uses NICE to approve new targeted therapies. Those then get listed on the Cancer Drugs Fund, and to prescribe these treatments, we have to fill out a funding application on a program called BlueTech, and depending on the alteration, we can approve some of these therapies in the first-line setting, meaning a patient who's newly diagnosed with stage 4 non-small cell lung cancer who's treatment naive, or in the second-line setting, or some of the other variants we're still waiting for NICE approval. Early molecular testing is critical. Molecular testing is needed to select optimal treatment. It provides insights into tumor biology. It provides prognostic information, and it guides initial therapy selection. So we can select targeted therapy and we can deselect immunotherapy and chemotherapy. So the typical way that lung cancer is diagnosed is with tissue biopsy, often CT-guided lung biopsy or an EBUS. That's done, sent to pathology, They confirm malignant cells. They then confirm that it's a carcinoma instead of, say, a lymphoma or sarcoma. They then use immunohistochemistry to work out the subtypes, such as adenocarcinoma, squamous cell, small cell. And then they move on to molecular pathology if there's tissue left over. So PD-L1 immunohistochemistry. Previously, we were doing single assay PCR testing, but now we've started doing broad panel next generation sequencing. And liquid biopsies use the same technology. So liquid biopsy and ctDNA, or circulating tumor DNA, means the same thing. It's a blood test that uses next generation sequencing to look for these oncogenic drivers. It's not currently NHS commissioned, and that's why we are involved in the pilot, hoping to get it NHS commissioned and get it on the test directory. And essentially, it is sampling the blood for tumor DNA. Therefore, the tumor needs to be shedding DNA into the circulation to get a result. So what is next generation sequencing? It is massively parallel sequencing technology that offers ultra high throughput, scalability and speed, and it determines the order of nucleotides either in the whole genome or in targeted regions. And whilst looking for these drivers, it's really looking for specific variants, substitutions, insertions, deletions, copy number alterations, or gene rearrangements or fusions. There's been lots of validated work done on ctDNA, and the data has shown that there's a high concordance between liquid NGS, liquid ctDNA, and tissue NGS, which is very encouraging.
Sorry, Marcus, sorry to interrupt you. I think Jenny just mentioned that the slides are not moving.
Ah.
No, they are for me.
Apologies if they're moving for, are they moving for everyone else?
Yeah, they are, Jenny. It's just you.
Oh,
Okay.
sorry, everyone. I'll come out and join back in. Sorry.
Sorry, Marcus, for the interruption. We can carry on from the real world data. Sorry.
Okay, no worries. It does look like my screen has frozen a little bit, but hopefully people can see. At a international oncology meeting called ASCO in Chicago a couple of years ago, a US professor, Professor Agarwal, presented this data where she showed that patients who have upfront tissue NGS and ctDNA at diagnosis have a significantly improved overall survival than if they have incomplete molecular profiling. And the reason really is that doing ctDNA and tissue NGS, you're more likely to find the driver mutation and therefore detect these variants and start patients on targeted therapy, leading to improved survival. Talking about some of the benefits and the pitfalls of ctDNA. So the clear benefit is that it's non-invasive. So for patients who have a tumor that is hard to reach by interventional radiology, it can be very helpful. Patients who perhaps are not well enough to undergo a tissue biopsy, or probably more commonly, patients that have a tissue biopsy, but there's insufficient material left over for molecular testing. It generally has much faster turnaround times, so often 10 days compared to something like 4 to 6 weeks, depending on where you are in the country and what your pathology setup is. For each variant, it gives a readout, and it gives a frequency of that variant in proportion to the blood, which can be helpful in assessing its importance and also going forwards for patients that have serial liquid biopsies. It gives an improved understanding of tumor biology. So not just the individual variants that may be the driver, but it also gives a broader picture of the landscape. And ctDNA is broad panel testing. There are a number of different commercial companies that offer this technology, and they often do numerous gene panel testing. What we're principally looking for is tumor DNA, but it's also able to detect germline variants that may be inherited. So, for example, BRCA mutations, and it can be used for other purposes, such as monitoring response to targeted therapy, or patients who are on targeted therapy being able to detect resistance mutations, which may then be druggable with other therapies. The downsides to liquid biopsy is that the tumour may not shed into the circulation, so it may give a false negative. We can't get a PD-L1 score from it. Relatively high costs. For a commercial test, it might cost several thousands of pounds. We're obviously in the pilot getting a lower cost. We're principally looking at adenocarcinomas, but so we're not finding many variants in other types. There's something known as CHIP variants, or clonal hematopoiesis of indeterminate potential, and this is really picking up variants due to blood cells, due to white cells, and it's sort of background noise. So it's not representing what's going on in the tumor. But occasionally we can actually pick up malignant hematological cancers through ctDNA. Some variants are more easily detectable than others. The fusions, like ALK fusion, is sometimes harder to detect with ctDNA. The reports can be challenging to interpret, and tissue NGS molecular testing remains the gold standard. Okay, there are several other different applications of ctDNA. At the moment, this pilot is purely focused in early diagnosis of advanced or metastatic non-small cell lung cancer. But going forwards, we're likely to see it adopted in other parts of the pathway with early lung cancer, and also looking at response and resistance to targeted therapies. So where to seek help when interpreting a liquid biopsy report? You can contact myself, your local pathologists, or the regional cellular pathologists at the genomic lab hubs. All the different regions are going to be offering, if they're not already set up, a genomic tumor advisory board, like an MDT, where you can bring the liquid biopsy report, and experts will be able to give a view as to whether it's actionable, whether a targeted therapy is available and would likely benefit the patient. You can ask national experts like Professor Greystoke, or you can contact authors of landmark papers. I think the key message is that not all variants are actionable or sensitive to targeted therapies, and really we want to avoid anyone starting a therapy that's unlikely to be effective. So a little overview of the pilot. So the aim, or the situation that we're looking to do these liquid biopsies in, is in a new lung cancer respiratory clinic. So patients have a CT that shows a new radiological lung cancer with advanced or metastatic disease. The patient attends the respiratory clinic, and in that first appointment, the lung CNS sends off a liquid biopsy. The patient then continues the standard lung cancer pathway of further investigations like PET, EBUS, CT-guided biopsy. And during that period, within 10 to 14 days, the report is issued to the respiratory team, and that's shared with the oncology team. And if there is an actionable driver mutation, then targeted therapy can be started by oncology before the tissue biopsy results are reported, thus making the pathway faster. Part of the pilot is to collect some data. We use an Excel spreadsheet, and that's going to be important in producing a final report and getting this technology commissioned. We have 3 phases of the pilot. We're currently at the start of phase 3. We started back in 2022, where the country is split into regions called GMSAs, and each region had 100 liquid biopsies to do. At that point, we were using a platform by Roche called Foundation One and sending the liquid biopsies to Germany in our region. We then moved on to phase 2, where we had 1,800 liquid biopsies nationally, split proportionally, and our region, our GMSA, which is called Central and South, is the largest region in the country. And so we sent off 387 samples, and all our data analysis was submitted on time. And these liquid biopsies we've been sending to the Marsden in London using a different commercial platform from a company called Guardant, who have something called in-house tech transfer, where their technology is being used in the Marsden, who are generating a report and sending it back to the local trust. We've now finished phase 2, and we've started this month phase 3, where we've expanded to 10,000 samples. At the moment, we're sending samples to the Marsden, but we're hoping that Manchester may come on board and we may send our samples there. We have 13 current active hospitals in our region, but we are hoping that more will come on board. In phase 2, I think we did particularly well, being the largest region. We completed our quota, I think, before anyone else. And on the right of the screen, you can see the hospitals that have been involved. Southampton University Hospital sent the most samples. But we have a very large region that includes Southampton, Oxford, Birmingham. You can see them on the map. And to summarize, the National Transformation Project, it's a feasibility study. It's not trying to validate the utility of liquid biopsies. That has been done, and countless papers have been published. A lot of the liquid biopsy, the commercial ones, are FDA approved as companion diagnostics. It's really looking to see if we can roll this out in the NHS, if we can collect some data and then get it commissioned. But essentially, it's a blood test with the aim of diagnosing lung cancer earlier, improving access to targeted therapies, and ultimately improving survival. The finer points of the project outcomes are to assess the quality of liquid biopsies, to try and meet our turnaround time of around 10 days, to make sure that the technology's identifying the oncogenic drivers, and that we are analysing and interpreting the reports and acting on them appropriately, and looking at the cost implications. It's possible that it may be a cost-saving endeavour, but we'll know more when that is published. So thank you for listening. I'm going to pass over to Dr. Geldart, who's going to tell us about one of his patients.
Thanks very much, Marcus. Kat, have you stopped the slides now? But because I could find whatever's easiest, that's fine. I can share my slides.
If that's okay, thank you.
Just check that you can see those. Somebody give me a heads up if you can see them.
Not yet.
Yes, we can. Yeah.
Yeah, they're there. Fine. Okay, that's great. So I'm going to give just a brief presentation about a case history. Just struggling with the monitor here. Fine. So a brief presentation about a case that we had in Dorset. This was a 32-year-old lady who presented via her GP, a referral direct into acute medicine. She was seen on the same day in emergency care, and she'd presented slightly worryingly with a 12-day history of pretty severe headache whilst driving. She had a bit of photophobia and she had a bit of neck stiffness, and on examination by the medics, she was also found to have a supraclavicular lymph node on the left, which felt pathological. She was otherwise well, with no real significant past medical history. She wasn't on any medication. She was working up until her symptoms as an accountant. She was a single parent with an 11-year-old daughter. And there was a very brief smoking history, but she'd stopped 9 years prior to her presentation. This is her MRI, which sadly showed a significant burden of metastatic disease. So on the top 3 images, you can see sections through the brain with some yellow arrows pointing to areas of metastatic disease, and then the darker areas around representing pretty significant cerebral edema around areas of metastatic disease. And then the bottom 2 panels, you can see what looked like a primary lung cancer in the bottom of her left lung, with some lymph nodes enlarged in the middle of her chest, and also a lymph node enlarged in her left supraclavicular fossa. So she was pretty quickly diagnosed as having metastatic lung cancer despite her young age, and was started on high-dose steroids to control her cerebral edema. It would be fair to say that her headaches were actually pretty difficult to control, and she continued to struggle with quite profound headaches. We saw her as an oncology team within a day or 2 of her being admitted, and we were able to organise a supraclavicular fossa node biopsy while she was an inpatient. We also arranged for her images to be discussed in the regional neuro-oncology MTT, and we were about to start the ctDNA pilot at that time, so it was pretty fortuitous really that everything happened at this point. About a week after presentation, although she'd gone home, she was still struggling with very difficult headaches and probably was starting to develop new seizures as well. She remained on high-dose steroids. We had to add in quite a lot of analgesia to control her headaches, and she was started on anti-seizure medication to prevent further seizures. In a timely way, the sample tubes and packets for the pilot arrived, and she was our first patient for whom we took a blood sample, and that sample went off 7 days after her radiological diagnosis. 10 days after her diagnosis, we had a turnaround from her tissue biopsy, and that confirmed non-small cell lung cancer. It was TTF1 positive and completely in keeping with an adenocarcinoma with a PD-L1 level of 25%. At that point, tissue was sent to the regional hub in Birmingham. And whilst all this was in play, she was also seen in the regional neuro-oncology clinic, and a discussion was had about stereotactic radiotherapy, and essentially the wheel set in motion for that to happen whilst we were waiting for results to come back. Day 20, a Monday afternoon, an email came into my inbox, along with many other inboxes, to give us the result of the serum testing. And what that demonstrated was that she had an ALK fusion within her lung cancer. It went on to give quite a lot of detail, and detail that probably we didn't really get from the tissue biopsies historically. So it told us about the variant of translocation. It also talked a little bit about a concurrent TP53 variant, which again is not something that we would typically see on a tissue report. The implications of a P53 mutation in this scenario is it unfortunately tends to define a subset of patients without translocations that don't do very well. The next day, I was able to see her in clinic, so a really rapid pathway when we went through the serum results and the tissue diagnosis, etc., and talked to her about treatment with tyrosine kinase inhibitor brigatinib. She was able to consent for treatment and go home with treatment on the same day, and at that point made the decision to put her stereotactic radiotherapy on hold, expecting a rapid symptomatic response to treatment. Clinically, within a week or two of starting brigatinib, she felt dramatically better. Her headache gradually resolved, her supraclavicular fossa lymph node shrank down, and we were able to start weaning her steroids and pain relief. After she started treatment, I think within probably the following week, we got her tissue gene panel result, which essentially confirmed what we found on serum. The reporting wasn't quite the same, and we didn't get a report about the coexistent p53 gene mutation, and maybe that's something we could discuss. Where are we now? 5 months into treatment, she's seizure free, she's off steroids, she's off pain relief. You can see on this January scan that the supraclavicular fossa node in the top left picture has resolved, and the top right hand picture, and she's had a fantastic response in her chest as well. With her brain scan, the edema has resolved and remains resolved off steroids, and the metastatic enhancing lesions are all dramatically reduced in size. So in conclusion, for this patient, she actually had a very quick diagnostic pathway, and probably a lot quicker than the average lung cancer patient. For her, the ctDNA pilot facilitated very rapid initiation of systemic therapy and rapid symptomatic improvement. It meant we could avoid giving her stereotactic radiotherapy to her brain for the moment, and also gave us a bit more information. And I guess just to echo Marcus's points is we've relied on tissue gene panelling for quite a long time now, but I think within the NHS we all struggle, particularly with wait times for biopsy, wait times for bronchoscopy, diagnostic misses. It can also be an issue, so biopsying into necrotic tumour or getting a non-representative sample. And of course, just manpower in the NHS is difficult, isn't it? The amount of staff to report things, package things up, send things away. I think ctDNA certainly at our end is very, very simple. Every day is a liquid biopsy day, isn't it? Every day somebody can have a blood test and we can package it off and send it in the post. And we've taken full advantage of this and been able to bleed 85 patients since we started in October. So it's been a resounding success for us.
Thanks, Marcus. Hi, can you hear me okay? Yeah, okay. So I'll just share my screen and I'm hoping you can see that. Is that all right? Can you all see that? Yeah.
Yeah.
So I'm Jo Wilson. So I'm a lung cancer clinical nurse specialist working in Southampton at UHS. And I've been managing the pilot here in Southampton. And I think we were one of the first trusts to get on board right at the beginning of phase 1. And to date, we've done 155 samples, I think, unless we've done some more today, which I wasn't in the clinic. So I'm going to be talking about logistics of sampling and how our nursing team really have managed this at UHS, and hopefully sharing some of our learning from it. So I'm going to be looking at the identification of eligible patients, issues around consenting, the logistics of really just getting the sample and sending it off, how we've managed the results, and also some of the challenges that we've faced so far. I'm able to sort of have a little look at some of the data that we've collected. So I'll share a bit of that and a quick case study at the end. So looking at the eligibility criteria for this pilot, they obviously need to have radiologically suspected stage 3 or 4 lung cancer likely unsuitable for curative treatment. You need them to have a performance status of 0 to 3 and a suspected or histological diagnosis of non-small cell lung cancer. So sometimes molecular testing will fail on the tissue, and so you have this as an alternative option to another tissue biopsy. You must, as part of the trial, one of the criteria is that you take the sample, the liquid biopsy sample, before tissue biopsy. Sometimes we do it the same day. This criteria is really good and handy to keep at hand because as nurses, I found that we've sort of almost become the gatekeepers of this test. And sometimes we get requests to sample patients slightly, maybe, you know, stretching these criteria a little bit. So having these criteria handy is really useful. And of course, also, if you're not sure, you can always ask your clinical lead for the pilot or your regional lead, or like Marcus was saying, you know, there's all sorts of other people that you can ask. I've asked Marcus quite a few times about eligibility questions, and he's been really helpful. So as lung cancer nurses, we meet patients really early in the pathway, and we see them in our diagnostic clinic. This is our preferred setting, really, to take the sample. We usually take it during that consultation. And because we screen these clinics, we screen all the patients in these clinics before they come, so we're pretty well placed, really, to identify the eligible patients. So until recently, nearly all of our patients have been identified in this way. And of course, we also support breaking bad news on the wards. And so if somebody looks like they're eligible, then we'll, you know, take a kit along with us when we do that. So because this has been very much CNS led, this whole project, we found it, well, actually, to be a bit of a double-edged sword for us, really. It's great that we have had ownership of the administration of the testing, because let's face it, nurses, we're all control freaks, right? But because we've been taking the lead on this and we've been doing all the screening, we have kind of noticed that a follow-on effect of that is it's taken a bit of a long time for the test to be kind of properly recognised within the MDT as a proper diagnostic option. So, and to be added like to MDT outcomes in a formal way. I think this is improving now, and liquid biopsy is definitely appearing on more outcomes without us as nurses having to prompt it. It's kind of feeling a bit more like a whole team approach now. So with regard to information needs and consent, there are a few things to consider. Firstly is timing. Obviously, you know, in that first clinic session, you're often explaining this test right after breaking bad news to a patient. So sometimes they're really overwhelmed and distressed, and it's not the right time. But for those patients that can manage the conversation, you know, we try to have the conversation then, because we realise it has an impact on the pathway for them, and it feels more comfortable because it is just a blood test to be able to offer that. So sometimes we need to bring the patient back at a different time, though, if they are too distressed, and that's fine. Most of the time, once we've explained this test to them, they're really keen to have the test done the same day, and we're doing that. So as also, you know, the simplicity of the test really sort of makes it feel more comfortable. Consent-wise, we just need verbal consent, and we should be offering the information leaflet. I've put a an example of the leaflet that we're giving out there now. That should be given. The leaflet warns a patient. I just wanted to make a point that it warns patients about detecting germline mutations that perhaps increase that patient's chances of getting cancer. And this is referring probably to the germline mutations such as the BRCA genes and things like that. But after a recent experience, I now go a little bit further, and I do say that occasionally we just get incidental findings, really, that we weren't looking for, and that could be cancer related or not. We had an unusual case recently where I bled a lady who turned out to have a Y chromosome. it was all a bit strange, and they were querying obviously sampling error, but it wasn't. So we ended up telling her about this, and she in the end chose not to have any further testing on that, and it wasn't thought that there would be any hereditary implications. This case was discussed at our GTAB meeting. So one of the big considerations when we started this pilot was the logistics of it, and actually, how are we going to get this sample? So, and where and all of that. So Kat's going to go through the process of using the kit. But it's worth having a plan for each setting. Okay, most of our samples, as I said, are taken in our outpatient clinic. We have trained HCAs that will do that. Sometimes, though, they're not available and we have to go down to phlebotomy. We've actually had made an agreement with phlebotomy that if we as CNSs have to accompany our patients down there, because obviously we have the kit, so they will fast track the patient through phlebotomy. And also, it's about being able to access phlebotomy on the inpatient wards if your lung cancer nurses are not phlebotomy trained. It's a good idea having somebody in the team to be checking that you've got enough kits. Now the process of ordering kits has changed now for phase 3. So whereas Kat was giving them out and sorting all of that out, now you are ordering directly from Royal Marsden, and there's an order form to do that. And it's a pretty simple order form, so it's not difficult to use. It's also really important to document when you've taken the test. So we upload like a standard memo template explaining that we've done the test and the expected turnaround time for the results. And that goes onto our documentation portal. We use Royal Mail special delivery to send these samples to the Marsden. We've never had a problem with that, not a single problem. They always get there the next day, been brilliant. It's worth keeping a tracking number just so you can put your mind at rest and check. I do strongly recommend that you keep a spreadsheet with dates so that you can track outstanding results and then chase those up if needed. We have had the odd issue where a results email has gone astray, and luckily we're able to identify this and contact the Marsden and get it all sorted. So this was just to show you a sort of an idea of what our tracking spreadsheet is like for phase 3. And we no longer have to submit data. So this is kind of like a shortened version of the big data sheet that we had to fill in for phases 1 and 2. And really, I've just coloured some of the columns green. So there are essential columns that we need to fill in, and the others really are just for, things that we might be interested in looking at auditing in the future. And that's a bit further along to the right. So managing the results. So at UHS, our current system is wholly managed by the lung cancer nurses, and our samples are not passing through our labs at all at this point. Now, we realise this isn't ideal because it means there's no formal acknowledgement of results by a clinician or a pathologist, as with your other diagnostic tests that you do. And obviously that brings a risk of failure. So to mitigate that risk, there's a few things we do. So we always use a shared inbox for those results coming in. So somebody is always available to check. And the results are copied to the local GLS hub, and ours is at the West Midlands hub. We haven't had any disasters yet, so we're doing okay. We are having conversations with our pathology and care group managers, really looking into getting this happening via the labs. And really, that's, I think, the whole point of phase 3, really. It's about integrating this test into business as usual. And so we've got that time to be able to do that. So the lung cancer nurses, we check our shared inbox daily. We then upload the results to the main results server. I should mention that at UHS, our clinical lead for this pilot, who also, of course, receives the reports, is a respiratory consultant rather than an oncologist with genomic experience. So initially, when we were getting these reports in phase 1, we were just flagging up the obvious actionable mutations to the oncologists. But this did leave us feeling a bit anxious about the potential to miss something that we didn't recognise. And because, of course, we haven't really had any formal genomics training either. So we felt that a clinician with genomics training really should be having oversight of every result rather than just the lung cancer nurses. So some say that every liquid biopsy result should be referred to the GTAB. So when we started the pilot, we didn't actually know what GTAB was. We weren't aware of it at all. And we've very much been finding things out as we go along. So unfortunately, the GTAB meeting at Southampton is on a Friday morning, which is literally our busiest time of the week with lots of respiratory and oncology clinics. But before sort of GTAB became an option for us, we had a meeting with our medical oncologists to try and find a solution to this. So what we did was we set up our own molecular markers, MDT. So this is currently sort of an informal meeting, but we document everything from it. It's a lung cancer nurse, it's a medical oncologist, and sometimes a clinical oncologist as well. And we look at every result we receive, and we decide if it changes the plan for the patient, and then document that. And any findings that we're not confident about or that are a bit unusual, we usually refer them onto our GTAB. So it's definitely worth finding out about GTAB in your area. Our oncologists are happy to present their cases at GTAB, although it's quite ad hoc, it's only when one comes up that we need. So that's how we do it at UHS, and it seems to be working quite well. We've had a number of challenges along the way. As I said, it's been a big learning curve. The pilot really has enabled us to learn as we go along. In hindsight, I guess maybe taking on this project with no genomics training meant that we spent a bit of time fumbling in the dark, feeling a bit vulnerable. This is obviously the nursing team I'm talking about. Thanks to our respiratory lead clinician, Dr. Land, and all of our oncologists, including Dr. Cave, who's on the call, and Marcus from Basingstoke. They've all provided really good guidance and support and answers to my constant questions. We've managed to find some useful training. I'm going to share some links in the chat once I've finished this talk, if you're interested. I feel like we've come quite a long way. We're feeling much more confident, and hopefully during phase 3, this will continue improving. Bringing the whole MDT on board and fostering a whole team approach has also been a bit of a work in progress, but we're noticing as awareness of the test becomes more widespread throughout the team, it's slowly feeling a bit less lonely. So anything you can do to encourage engagement of the wider team is going to pay dividends. Ensuring the test is available to eligible patients, and all eligible patients. We noticed that some patients that had come via other teams sometimes have already had their tissue biopsy before we've even met them. So we sort of missed a trick there, really. So we contacted these other teams and really to let them know that we've got this test, and to let us know if lung cancer is ever, suspected in their patients. We also contacted our peripheral clinics, and we have a respiratory service at Lymington. So they're all also aware that this test is available. So one of our main challenges was the admin burden, and that's always been, been quite a significant burden for the lung cancer team. Us at Southampton, we don't actually have any dedicated admin in our team, so the nurses have been doing it. Most of that, of course, was the data sheet, which we now don't have to do, so that's a relief. I think we were quite lucky. The GMSA gave us a little bit of extra funding, and that helped with funding some overtime to be paid to get that data sheet done. I think at the start we were doing our best to fill in the data sheet, but we weren't really very well equipped for the job. And although we tried to be consistent in completing the fields, I do wonder, I think there probably are a few inputting variations that are going on. That's all been sent off now, so that's good. So the next challenge for us really is to incorporate this test into our UHS testing sort of directory, whatever you call it, and for the test to be processed through pathology, ready for business as usual. It's always a bit of a funding issue here, and so we'll be having more meetings, I'm sure, just to get this sorted. But I think taking all that into account, the team very much feel that if we had waited to get all of these ducks in a row before we had started, I think there would have been, well, we know there would have been several patients that could have missed their window for treatment. And I'll be presenting one of those in a minute. So looking at our data, so obviously we've sampled a lot of patients. So in phases 1 and 2, we sampled and collected data on 145 patients. We sent full data on 115 of those. And that's because the remainder didn't have full tissue histology for comparison or treatment decisions made. So we couldn't send that data. And those were the ones you can see there, sex not recorded. That was just because we didn't send the data. The mean age of our patients was 69. Now, of the data that we did submit, of that 115 people, 40% of those were adenos on tissue biopsy. 10% of them were squame, and 3% were classified as other, perhaps like unable to differentiate between the two. When we looked at the radiological staging, 23% of patients were at stage 3, the same at stage 4A, and the highest proportion was stage 4B at 45%. So this slide shows a comparison of the turnaround times we measured for both ctDNA and tissue biopsy. You can see that the mean average turnaround time from when the sample arrived in the lab for the ctDNA testing was 12 days. Now, at the start of phase 2, this testing at Royal Marsden was just getting going, and it was taking a bit longer because they were sort of getting all set up. So hence the range being up to 20 days. I suspect if we did a sample of them now, that would be the mean average would be lower. At UHS, we're typically waiting 15 days from the date of the initial histology report to getting full NGS reports. And this obviously is all from our data. This means the total turnaround time from biopsy to full molecular results is 26 days. So we then looked at the time it took to get patients onto treatment. So we compared the timelines of patients where we found an actionable mutation with those that didn't. And we measured from the date of the first diagnostic OPA, and it's often the date of their first CT in our trust. And we measured from there to starting on treatment. And you can see that patients where we found an actionable mutation in the blood, we were able to expedite their pathway by 27 days, which is really significant. We found several different mutations that are seen in non-small cell. Most common was KRAS, which we know isn't actionable in the first line. We found 6 EGFRs that were actionable, plus other mutations, including BRAF, ERBB2, MET, and a non-actionable ALK and other non-actionable EGFR variants. So the question that is perhaps most important to us all is the final question on the data sheet. Did the ctDNA testing make a difference? Well, we found that it made a significant difference for 14 patients. Now, 6 of those were faster genomic information. Obviously, that was all our EGFRs that we got straight onto a TKI. For the other 8 patients, it was about having additional genomic information. And for 3 of those, that meant we avoided having to get tissue again. So we didn't need to get a second biopsy. For 4 of them, it actually facilitated decision-making for best supportive care. So that's people who actually said, I don't think I want to be put, I don't think I'm fit for chemo. I don't think I really want to be put through a biopsy. So we said, well, let's see if you've got anything that we can target. in your ctDNA, and if so, then we'll go and proceed to biopsy. So that was really helpful for decision making for those patients. And also we have found one where we did one sample where we actually identified a different primary tumour site from it. So when we looked at the accuracy of the ctDNA results compared to the tissue results, we found that, and that is so looking, did every mutation that we found in the tissue, did we always find that in the ctDNA? And 97% of the time we did. So there's only 3 cases where we didn't. And actually, I'd quite like to spend a bit of time going back looking at those 3 cases to see if there were any clues in those reports that actually meant that we could have seen that that was going to be the case. I think that'd be quite interesting. So looking at a case study very quickly. So this lady, she's a 47-year-old female. So this is from a year ago. So we met her almost exactly a year ago. She was a never smoker, very fit, had minimal past medical history. She was working long hours in a really high-powered, demanding job. And in fact, her job was actually her lifeline. You know, it was her life. It defined her. So not being able to work was going to be really, really devastating for her. So initially, she presented to her GP with reflux, cough, fatigue, and breathlessness on exertion. She had some antibiotics, symptoms got better, but then they returned. So she had a direct access CT, having had 2 chest x-rays over a 6-week period. And there was significant worsening on the second chest x-ray, to the point where obviously they felt an urgent CT was needed. We saw her on the 11th of April last year, the same day, the same afternoon that she'd had her CT in the morning. And it showed a suspicious 22mm right lower lobe lesion. She also had an 18mm lesion at the right hilum, multiple areas of lymphadenopathy, and plus the impression of widespread bilateral pulmonary mets. They classified this as a T4 N3M1A cancer, and there was a question whether this might be a small cell due to the rapidly increasing size of it. So that day we took a liquid biopsy sample. We've done quite a few where we thought it might be small cell, and it wasn't. It was non-small cell. So we always take a liquid biopsy. And she was referred on for PET CT EBUS and an MRI head. And that MRI head isn't because she had any signs or symptoms of CNS disease. It was literally that we thought it might be a small cell. So she had a PET CT about a week later, which showed intense activity and avidity, in the right lower lobe lesion. She had everything else was avid, really, you know, the lymph nodes. She had a right supraclavicular node and hilar bilateral mediastinal nodes as well, and several avid bilateral lung lesions suggesting METs. So the timeline here is, so she actually had that PET CT on day 7 after we saw her. She'd had the MRI head scan a few days before, but reporting took a little bit of time, I think. She had 11 METs on that MRI head, sadly, and you can see one of them on that image. So she had her EBUS done, which showed lung adenocarcinoma. And so we realised, oh God, we've got to get her to clinic. So actually we brought her up to clinic before the lung MDT discussion in order to tell her about these brain mets and check that she wasn't driving. And as I say, she had no symptoms of brain disease at all. The staging was confirmed T4N2M1C at that point. On the day after that, we had our lung MDT, and it was discussed at the lung MDT that actually she had insufficient material for any kind of biomarker testing at all. We didn't even have a PDL1. So she was going to have a CT guided biopsy. So we knew from that date, booking the biopsy and then waiting for all those molecular markers, she basically would have been on day 52 when we got those results. So it would have put her through another procedure. And this lady was highly distressed. I think she's probably one of the most distressed patients I've ever seen. On day 16, so actually the same day as the lung MDT, although we didn't know it at the time, her ctDNA report had been finalised, was being sent to us, and that showed an EGFR exon 19 deletion. And so we were able to see her in clinic very quickly. We had teed her up for SRS to the brain, which obviously then got shelved. Oh, I ought to just show you, this is the report. So this is one of the reports from the Foundation 1, which is what we were using during phase 1. And so it looks a little bit different to some of the ones we've been getting more recently. There is a chance, I think, we might be going back to these reports in the future, and they are really easy to read. So they're really good. So we got her seen by medical oncology on day 25, and she got started on osimertinib, a TKI, the next day. Her pathway was expedited by about 27 days based on sort of likely timeframes of that CT guided biopsy that we didn't end up doing. And I think really reflecting on it, looking at how rapidly her disease was progressing on those chest x-rays, I think waiting another 27 days could have meant that this performance status 0 lady could have actually missed her window of treatment. So this ctDNA test, made an absolutely huge difference for her. And a year later, this is what I can report. So she, in August, she had restaging scans, and she had a good response to treatment pretty much everywhere. So the lung showed really good response. The MRI head in August showed significant improvement. I think pretty much you can't even tell that there's any brain mets there anymore. And in March, she was still stable in all sites. She continues on osimertinib with almost no side effects after 1 year. And most importantly for her, she's been able to continue working and being independent. And I think that's been a game changer for her. So that's it. Thanks for listening. I think we'll do questions at the end, I believe, and I'll put those learning points in the chat.
Thank you, Jo. Excellent talk. Really compelling data. Shows that what a game changer liquid biopsies are. I'm going to hand over to Professor Greystoke, who's a professor of precision oncology. He's the clinical director of the North East Yorkshire GMSA, and he's going to talk about ctDNA report interpretation. Over to you, Alistair.
Yeah, I think the slides are. Can you advance them all the way forward, or shall I share my own? Is that going to be easiest?
I'm trying to load them. Just bear with me 1 second.
Well, yeah. So first off, just as we're doing that, thanks very much for inviting me to talk. Is it going to be quicker for me to share?
Is it okay if you can share? I'm just trying to move to the slide.
Let me see if I can do it. If you stop sharing, let me see.
Okay.
Let me see.
If it's difficult,
PowerPoint live. No, it's not.
No, okay, don't worry. Don't worry, I'll share.
Teams and Macs don't like each other, so want to go PowerPoint live. There we go.
Can you see the slides?
Yep. Yeah.
There it is. Okay.
Right. So yeah, thanks very much. And let me see if it'll now move for me. If not, I might have to shout at the next slide. Hate Teams sometimes. Just go next slide, then go on. And unfortunately, there's some animation, so I'm going to sound a bit like Boris Johnson. So my apologies. So next slide. So the things I wanted to talk about today are just to say, talk you through very basically, I don't have very long, about how an approach to interpreting these reports. So the first thing is that when you first see these reports, you think, oh my God, they look complicated, and we'll see some pictures. We've already seen some quick pictures of them. But there's only 3 very simple questions that you need to ask it yourself. Is number 1, is there actually tumor DNA present? So we're measuring circulating free DNA. We all have DNA circulating around our body. What we're trying to work out is, does your patient have any tumor DNA present? So ctDNA. If they do, is it one of these ones that we've heard about before, where they've got molecular abnormality and I have a tablet that I can use to give to them? So is there a targeted treatment available? But equally as important, maybe a key negative. So can you use it to exclude a targetable abnormality? Say the patient, no, you can't have a tablet, and either we need to get cracking with chemotherapy and immunotherapy, we don't need to wait for the tissue. I'm confident that we can go forward and do that. Or as we heard before, and with a number of my patients, they may choose either not to have a biopsy or not to have a treatment if they can't access a tablet, and the other options for them may be only chemotherapy. Next slide, please. So, and next slide, please. So, next slide. So, yeah, this slide. So, the first thing to think about is trying to work out that key question about whether there is circulating tumor DNA present. And I guess one of the important things is, what's the minimum pickup? So, as we'll see, they will report for you a number of genetic abnormalities, and then often what is called the VAF, which is basically just the percentage of that mutated DNA in the blood. So we're looking for mutated DNA from a tumor, and we're trying to work out, is this tumor DNA? So rough rule of thumb, and there's a very basic calculation there, is that a whole genome equivalent, so if you had every single, the DNA for every single gene in your body, it makes up about 3 picograms of tumor DNA. And this is taken from Mike Eubanks of Nicholas. And if you take the 2 tubes of blood that we sent in the post, that comes to about 30 nanograms of DNA when you extract it out of the blood. And that works out to about 10,000 molecules of blood, of DNA in those 2 tubes of blood. Once you get below about 50 molecules, the technology struggles to pick it up reliably. You start to see, weird and wonderful things occurring, just artifactual. So the boundary is around about 0.5% that you can be very confident that you are picking up something that is genuine. If you're getting less than 0.5%, you may be missing something, or it may be a false reading due, sequencing error in the technology. But occasionally that may be valid. So if you had a young never smoker, as we saw before, 30 with multiple brain mets, and you saw an EGFR mutation at 0.25%, I would believe that. Okay, I'd feel happier if it was above 0.5%, but in general, somewhere about 0.5% is about right. If it's less than 0.1%, you really have to have a fair degree of skepticism. Okay, next slide, please. This is where we're going to go into Boris mode. So can we pick up all abnormalities? So next slide, click. So mutations are relatively easy because so what I've done here is shown your normal DNA in circulation is green, and in a mutation it will look very different to your sequencer. So it'll look red, and it's very, you can see straight away there that we can pick those out very easily. Next slide, please. However, it may be more difficult to pick up what are called amplifications, where we're looking for more copies of genes. And so you can see, if you just give a click, please, Kat. Hopefully it'll show up there. You can see that particular gene, we've got more copies, but until that little red circle went on, it may be very difficult to pick it up. So amplifications are more difficult to pick up. Next slide. And looking for a deletion where it's missing, where there may be a gene missing, can be even more difficult. So again, just give a click, Kat, and you can see, only then can we see it. And next slide, looking for a fusion where you're looking for a very small change, there's a little red dot there, can be very challenging. Next slide. And actually just click all the way through this one, because I'm not going to go on to that one. Just click all the way through until we get to the next one. That's basically just making the point it's easier. The more tumor DNA it is, the easier it is to find things. Next slide. So one of the things you need to be aware of is that not all patients will have circulating tumor DNA. And there's certain things that you can use to predict the chance that your patient may have circulating tumor DNA. So on the left, we have a study that was done in 2015, so quite a long time ago when we started using this technology. And even at that time, you see that patients that have lung-only disease or brain-only disease have much less access for circulating tumor DNA to the circulation. And so you may miss these. If your patient has lots of bone disease or liver mets, almost certainly you will pick it up. But if it's lung-only disease or even pleural-only disease or brain-only disease, you may miss it. And on the right is an interesting bit of analysis that shows the bigger the tumor, the more likely it is to shed DNA, but it's not a pure correlation. Some tumors will shed more DNA than others, and often that is associated with a worse prognosis. Next slide, please. As Mark has mentioned, you can also get false positives, so you can get what's called this chip, which is due to aging in our DNA. And if you get old enough, you will have mutations in your white blood cells due to the carcinogens we are exposed to day in, day out. The good news are these are normally in set genes, and these are often genes that are not related with lung cancer. So the most common one is a gene called DNMT-A3, and you will see abnormalities in that in about 30% of patients. And in general, you don't need to do anything about it. It's just background noise, as Marcus said. Next slide, please. Frozen for me. Hopefully it hasn't frozen for, oh, there it goes. So these reports, what you'll normally get is you'll get a list of the mutations that they're found. And in most patients, that will be somewhere between 1 and 5. And they will give you a percentage, which may be written as a percentage. It may be written, it may be said VAF, which stands for the allele frequency, but in general, it's the percentage of the mutation there. And often they will also give you some interpretation. So on the left is one from Foundation that we saw before, top right is one from Garden. They'll give you your pretty little diagrams. And in the bottom is the ones that we're now presently getting from the Marsden. But in general, they will tell you the gene, they will tell you the mutation if you are interested. You may or may not be interested. They'll tell you the percentage of that tumor DNA, and certainly from the Marsden as well, they will tell you whether it's pathogenic or oncogenic. Is it causing your patient's cancer? And they may even give you some interpretation as to what treatment to use. Next slide, please. It does sound really worrying. You see, will start to see more gene results coming back there. So, for example, we heard earlier from Marcus, and in that abnormality, we saw that they had analyzed P53, and we're not used to seeing this. Why are we all of a sudden getting P53 results? And the reason is because that's actually really a common abnormality in cancers. It's present in 50%. So if we see it there at decent levels, although we've not got anything we can give a tablet to, we know there is tumor DNA in that patient's blood sample, and we are not missing anything. So that is a key negative. So that's why you may start to see these reports coming back, is you'll see that P53, and that is a very common abnormality, and that tells me I'm not missing anything. Okay. So there, and people worry about, oh my God, there's these hundreds and hundreds of genes that I need to look at. But there I've shown that those are the 20 most common genes that you will see in lung cancer. You will see these ones time and time and time again. And the ones in blue are the ones that we can give treatment for. Okay. So it does seem very challenging to start with. It does get easier over time, I can assure you. Hopefully I haven't scared you silly. Next slide. And the second last thing I'm going to say is, please do treat. Okay, if you get an EGFR ctDNA, you do not need to wait for the tissue. This is the form that Marcus said, which is, as oncologists we need to fill in. So this is NHS funding that now says, if you find it in a liquid biopsy, you're confident the patient has lung cancer, you can treat straight away. You do not need to wait for tissue. Next slide. So very quickly, we've heard a little bit about germline findings. Actually, in lung cancer, they are pretty uncommon. This paper looked at this in over 50,000 samples and found that in lung cancer, you will see them in about 1 or 2% of patients. It's about 6% in all cancers. You'll see you'll see a germline finding in lung cancer, but about 1 or 2%. But it will happen, as we've heard. You know, Southampton have done 150, so you will pick up 1 or 2 germline findings. Next slide. But actually, cfDNA can be helpful for this. So this is one of my patients who had lung cancer, and they had an abnormality in KRAS, which is a very common finding. But you can see there's also an abnormality there in BRCA1, and you're thinking, oh my God, is that germline? But if you see the percentage, it's 7.8%. So that's only 7% of their DNA traveling around their blood has the abnormality in BRCA. Now, if it was coming from the germline, it should be in 50% of your DNA approximately. So the fact it's only in 7.8% means I know this is actually coming from the tumor, and in fact, it's probably only coming from half the tumor, because 15% of the DNA has a KRAS abnormality. So very quickly, I can say, actually, I do not need to worry about this. It's only 7%. It's not 40, 50, 60%. It's not germline. I can ignore this, at least from the point of view of a germline, and can leave this to the oncologist. Next slide. And so the last thing to say is that discrepancies will occur. Okay, it can be very confusing. You've got a blood result that says one thing and a tumor result that says another. Every study that's looked at this says that the vast majority of patients, you will see the same things in tumor and blood, but you will sometimes see differences, and this is to be expected. It may be because your biopsy is wrong, because it's necrotic, you've got low DNA content, or it may be that your blood's wrong because you just don't have any circulating tumor DNA and it's been missed. But it will happen. Don't get confused, just expect it. So last slide. Just go back to the beginning. These reports do look complicated. It is a learning experience. I reckon you probably need to see about 50 reports before you feel comfortable with them, but don't shy away from it. This is going to be an important part of our workload and does lead to benefits for patients, as we've talked about. So just those 3 questions. Is it present? Can I give a tablet? Or can I be sure that I don't, that there is tumor DNA, but I still can't give a tablet, but I can crack on with chemo or best supportive care? Use your local experts and your local GTABs, and please just don't fill up my inbox because I get enough. Thank you very much.
Thank you, Alistair. Excellent talk. Kat, over to you.
Yes, I'm just going to pull up my slides. Just bear with me 1 second. I think if it can work. Hopefully it doesn't take us back to the start. Has it taken us back?
Yes.
Yes, it has.
Oh, sorry, unfortunately, Teams is like really slow. Okay, I'll just stop this way and I'll go the conventional way, if that's okay. Can you see the slides? Right.
Yep.
And I'm just making sure I'm not muted. Great. So as it was mentioned earlier, like this is an NHS improvement project set up to look at the feasibility of ctDNA testing with a view to commissioning the test into the National Test Genomics Directory, test directory. The project, as mentioned earlier, is aimed at respiratory teams for first point of testing. And ctDNA testing is done prior to tissue biopsy for patients with a radiological evidence of advanced lung cancer. So for onboarding of new hospitals and new sites, please contact myself. I've got my email, but I will also email you the details as well. And you will receive all the supporting documentation via email explaining all the next steps. And in the next few slides, I'll briefly go over the pathway and the processes. So we have entered the phase 3, which started on April 2024, and it will run up until 31st of March 2025. There was an expression of interest earlier last year, followed by which North Thames and Northwest GLH will be providing testing in this phase. As mentioned, North Thames will continue to provide testing until Central and South region moves to Northwest GLH. Hopefully, we will see that in July. So please be aware that the pathway will change going forward. So this is just an interim process. Northwest will implement a bridging solution until testing has been validated in-house, and we expect that for 9 months. But we will try to ensure that there are no delays and impact to the service. This slide sort of highlights the sample pathway for phase 3, indicating who's responsible for what. Existing and new sites are to request blood collection kit by completing and sending a form to Marsden 360 lab. Marsden will reply with instructions and SOPs and order and deliver the complete kit to the sites. Once patients are identified, you'll draw blood, complete the test requisition form, post using the prepaid postage and the boxes, prepaid safe boxes, within 48 hours of venipuncture. Samples are then processed at the Royal Marsden lab, and results are returned via nhs.net in a secure email in PDF format currently. And it is the responsibility for the referring trust to upload the results to their EPR system. So there are all these snapshots or these images that I have in the next few slides will be included in the instruction documentation. So these instructions are from the instruction for use documentation, explaining ordering, blood collection and shipping procedure. Royal Marsden will provide blood collection kits to NHS Trust, which will consist of, so each kit will have 2 blood collection tubes for per patient. It will have packaging including absorbent tube pouches, biohazard bag, and prepaid postage for return of samples to the Marsden Clinical Genomics Laboratory. Please note 1 blood collection kit per patient. To access NHS Trust, will need to complete the ordering form, which I mentioned the last slide, detailing the number of kits required and where the kits need to be sent, including contact names. Allow approximately 3 working days for the kits to arrive to your site. Again, with the instructions that are in the IFU documentation, it details how to draw blood, sending the samples to the Marsden lab as well. Please note that the blood that you draw does not need to be kept in a refrigerator or frozen, and you will need to provide the patient with a patient information sheet, and no signed consent is required. So it's just a verbal consent to them. So just a few of the shipping instructions. Ensure the blood bottles and completed Marsden 360 test requisition forms are placed in the blood collection kit as per the instructions and securely seal the box. Record the Royal Mail tracking number on the postage label to enable tracking during transit. So as Joe had mentioned, that it's really good for your own check internal process as well. If you keep a check on, what samples you've sent out, as well as just track those tracking numbers, so in terms of if you've not received a result and you're expecting, you can chase it very easily as well. So once all of that is done, you can return the kit to the clinical genomics at the Royal Marsden via using your trust post room. And the kit should arrive at the Marsden within 48 hours, as mentioned. So just make sure, like when you draw the blood, if it's on a Friday, you have to ensure that it's sent out so Marsden receives it Monday morning and they can extract the DNA from the bloods. Results, as mentioned earlier, will be emailed, and just make sure you include the referring clinician, the regional genomic laboratory hub, as well as the lead oncologist. So this is just highlighting the different precautions and limitations, which are, again, all detailed in the documentation that I will share with you. And just be mindful that the tubes are glass, so please use the padding that is provided. And another thing to note is the test requisition form. It is a digital form, an electronic form rather, and you can sort of pre-fill it, use it like a template and just input the patient details so that it's easier and you don't need to start filling every time all the details. And just another note to remember is for hospital ID, if you can use the hospital code and hospital number, it's easy for Marsden to also track which hospital the request is coming, and also keep a copy for your reference. So this is just my last slide. So, in terms of key stakeholders for our participating organizations, it's really crucial that we've got respiratory clinicians, oncologists, and the CNS teams involved from the very beginning. And we have seen with phase 1 and phase 2 that the CNS teams have been the driving force and the factor in terms of the success of this pilot so far. So having them on board is really important as well. So lastly, I think Marcus also touched on Genomic Tumor Advisory Board. Again, there are multidisciplinary groups that play a pivotal role in interpreting complex data, genomic data. So really link up with them as well. We have 3 GTABs running across Central and South. We've got one in West Sussex, West Midlands, and Thames Valley region, covering the Oxford Thames Valley region as well. So if you want more information about GTABs, please contact me, or you can email the GMSA admin email address that I have included as well. I'll stop sharing here, and so we will just bring the floor to any questions that you may have.
Thanks, Kat. Thank you to all of our speakers and organisers, and thank you to the audience for taking time out of your busy day. Any questions?
I'll just make a comment whilst people are thinking of questions. Joe, in my case that I presented, there's just this sort of difference in the reporting and the difference in the detail of the reporting for tissues and blood samples. Maybe the panel wanted to talk about that a little bit.
Yes, shall I take that? So there is different nomenclature, and particularly when you start to talk about fusions, they can start to talk about, you know, breakpoints and changes. I think don't get too hung up on the details. You know, the important thing is the ALK fusion, and you know, whether it's type 1, type 2, type 3, that's for biomarker nerds like myself. I think the issue about the P53 being reported is challenging, because at the moment we can't do anything, and when you're seeing your nice young lady and you're saying, you know, we've got an ALK, and then you say you look at the data, and in general they suggest, well, you'll get 3, 4, 5, 6 years with your ALK inhibitor. But actually, if you look at those that have P53 and brain mets, unfortunately, it's going to be less. Now, do you share that information or not? And I think that's challenging when it's not going to change the treatment at present time. There are, you know, studies coming through, particularly for EGFR, where we may be intensifying treatment up front for key patients, and that's the information we might need as oncologists. But at the moment, I think it's challenging to know how much to share, particularly when it's early days and you don't know. I don't know what other people feel, whether we should be giving. I can see Mark's put his hand up there. You know, I think this is a difficult area, so he might want to comment.
I wasn't going to comment on that, but I've got a few questions.
Okay,
so just before you get to that, then I guess in terms of what I did for this patient, because actually this is the first patient that we'd bled, and suddenly I'm faced with this very young lady with brain metastases in front of me. I mean, it certainly made me a bit cautious in what I was saying to her. And if if these folk go onto open groups like ALK groups, that there's a different conversation that goes on, isn't there? Really. So I've found myself being quite cautious in terms of the conversations I have with her, which actually is a little bit more difficult for me and a bit more difficult for her. But it is what it is, and you just have to project that uncertainty, I think. But just for discussion, I think. Okay.
I mean, my question was very medical oncology kind of related, because I'm a medical oncologist over at Walsall. But how you've got your EGFR and you've got your ALK, where you know you're going to treat them as soon as you see them. With some of the others, like your KRAS, if you get a MET exon skipping, on these other ones, do you have to wait for your histology to say, well, this is definitely a lung cancer? Because there may be some where you say, oh, well, that mutation could also be present in a different type of tumor that's not lung cancer. So I was just wondering how influential those other ones are, and have you taken some of these where you've got straight in and treated those without waiting for the histology?
So MET, yes, MET exon 14,
Yeah,
is
I
pretty
guess that's
lungy, and it's a first line treatment. KRAS is very widespread across lots of tumor types, and you cannot say that it's a lung because sometimes you're like, oh, is this a lung cancer or not? And you don't, yeah, you're right. KRAS is colorectal, pancreatic cancer, so yeah, but you don't treat that one first line anyway. So
no. Although we've got trials that are running it first line, so that's also a bit tricky. I guess you've got to wait for the histology for those.
Well, I'd be interested in Marcus's thoughts, but if my radiologist says this looks like lung cancer, I can see a lung primary, I can see pleural disease. You see KRAS G12C at 15%. I'm pretty confident that's going to be lung in the smoker.
Yeah.
You can always write the histopathology report even before you've seen it.
Yeah.
but that takes expertise.
Yeah.
I think it does depend on a case-by-case basis. So, for example, if you had a BRAF V600E mutation, then you'd correlate with the radiology. But you could start on first-line treatment if you thought it was lung-related. I think the other benefit of ctDNA is thinking about clinical trials when you do pick up variants that don't have an approved or reimbursed NHS treatment, and so it's always useful to contact your regional trials teams or sometimes even national to see what's available.
Yeah, and I guess one of my other questions is the GTAB. So I'm kind of a distant member of the GTAB because our local GTAB is full of pediatric cases and brain tumors, because that's where most of our sequencing comes in. That's in the West Midlands. So if we put in a ctDNA result that we're a bit uncertain of and we'd like a bit of help with because it's slightly unusual in some way, are you expecting, is there that kind of lung cancer expertise in the GTAB, or are we looking to get some more medical oncologists involved in these GTABs as we're going to help with the interpretation?
So I can just speak I know that we have established a good GTAB pathway for Wessex. And in terms of, I am working with West Midlands, and I know that their focus is very brain and pediatrics as well. So yeah, leave that with me, and I will get back with more answers in terms of what do we do with this, because we are currently working on establishing a a pathway for other cancers as well.
Right. Certainly get me involved.
I was meeting with NHS England today, and we talked about setting up a super national GTAB for other GTABs to refer their cases where they weren't comfortable just for a year to support, because different GTABs will have different expertise. But Judith can sort out for you. She knows stuff.
Thank you. I think Patricia's the next hand up.
Thanks. It's a chest position oriented question. So if we find TP53 but no targetable mutations in the blood, and then our tissue fails, they've had a bleed and it wasn't diagnostic, and they can't have another tissue, and can we do anything with that? Can we diagnose lung cancer if it's radiologically typical? Can we do anything in terms of treatment, or is it just, what does it mean?
We had a long discussion about this at BTalk, and the short answer is, if you're going to do something like that, it does depend on the VAF, the radiology. This is just a contributing test. P53 is found across all cancer types. It will not tell you it's lung cancer. If it's there at 10%, it will tell you this is cancer. It won't tell you it's lung. The radiologist, then you may say it is. It would be a brave oncologist who would treat on that. I am a brave oncologist and have treated in that sort of circumstance, but many other people would not. And I would certainly only do that with MDT sign off, multiple discussions, and a very high, a proper VAF where I was confident it was cancer. My radiologist said, yes, this is lung cancer. So not to be done routinely.
It's really helpful, thanks. We went back and did a high risk biopsy.
I would add that then reverting to tissue to get the subtype adeno or squame, that then helps selection of the chemotherapy backbone. So it is needed.
Thank you. That's
Judith.
what we did.
Oh, I was just going to say, to the point, Mark, you made about the GTABs. So in our GTAB, I go, like if I have a lung case, I go, and I think I'm probably the person who knows the lung stuff there, and I feel that's my responsibility. But what is so amazing is getting the expert genomic input from, you know, people who know way, way more than I do about the germline stuff. So yeah, I find it like a really good collaboration, and I don't think I'd want to see just a lung GTAB, because then I wouldn't have the amazing, like, the input from genomics, which is really useful. I don't know what you think about that.
And they help you with those variants of uncertain significance where you're just like, oh, I don't know what that means.
Yeah, and they just bring the common sense.
Yeah,
you know?
they do. Yeah, you know, that kind of makes sense, because of course the GTAB is not just the clinicians; it's all of the the kind of
the technical stuff,
the technical and the genetics side, which is really useful. Yeah, you make a really good point there.
Any other questions? I can't see any hands up. Thank you for joining us. Let's draw the meeting to a close.
Great, thank you so much. Thank you everyone for joining, and thank you speakers as well for your participation and wonderful insight. I will try to get the recording out soon, and we will share the slides as well. Once again, thank you everyone. Have a nice evening.
Thanks all. Good night.
Bye.